Good afternoon and welcome to Bridging the Gap Subcommittee. I'm Jim Van Dorn filling in for Commissioner Martis, who happens to be overseas at this particular time. We have two people that are excused today, Mrs. Colley and Judge Morgan. And with that, we're going to move right into the agenda because we're on a time constraint today. There'll be 20 minutes for each one of your programs and then a 10-minute answering people period, and we will let you know when those times run out because we're going to have to stop right at 20 minutes. So first of all, I'd ask for approval of the minutes of July 16th, 2025.
If there are no additions or corrections, I move to be accepted as submitted.
Support.
I have a motion by Commissioner Collins, supported by Sheriff Bevere. Are there any additions or corrections? That's my line, Commissioner. I have to ask that one. Are there any additions or corrections? Hearing none. All those in favor signify by saying yes.
Yes.
Opposed, no. Motion carried. Old business. Does anybody have any old business? Hearing none, we'll go right into new business and presentations, and we'll start out with Recovery Community Center, and we have Mr. and Mrs. Vargas here from McCullough Vargas and Associates.
That is correct. Thank you all for being here. Thanks for having us. And thank you for your time, that you've committed to this process and this program as we, work together to try to meet the needs of the community when it comes to substance use disorder treatment. So I want to thank you all not only for being here, for your dedication to this process as well. So let's start with some introductions of ourselves. I'll let my colleague go first here.
Hello, good afternoon. My name is Melissa Vargas. I'm the Executive Director at MBA Behavioral Health Services. I have a master's degree in social work. I've been in the field for 17 years. I'm also a person who identifies as being in long-term recovery. I've achieved my clinical certification, and I've also been certified as an advanced alcohol and drug counselor.
Yes, and I'm Ryan Vargas. I'm the Executive Vice President, MBA Behavioral Health, also a master's level clinician specializing in social work, certified alcohol and drug counselor in the state of Michigan, also have specialties in dialectical behavioral therapy, and I'm also a peer recovery coach as well. And with that, that means that I'm also a person in long-term recovery, and I'll be coming up on 18 years here next month. So been in the field for 17 years. I've been in my position as Executive Vice President for the last 4 years, I think. 4 years now. And yeah, so that's a little bit about me. And I'll let Melissa take it away with the first proposal.
Thank you very much. So this specific proposal is the Recovery Together Community Center. A little bit about MVA as a whole. We have been providing services since 1990. We have been CARF accredited since 1996. And our clinical leadership team has over 50 years of combined experience specifically in substance use. We have a known reputation in Lenawee County and surrounding areas for being experts in the field, meeting community needs, listening to what people might want, need, could benefit from, and then developing our programs to suit those needs. We created a residential substance use program in Hillsdale County and have been successfully running that for over 2 decades. We also created an intensive outpatient program here in Lenawee County, and that's been running for about 3 or 4 years. And that was the first of its kind way back in the day, if you remember Sage Center, but that has been closed for quite some time. So we've been known for finding community needs and responding. And that's why we're presenting the community center. Our mission at the Recovery Together Community Center would be to guide individuals toward wellness and create a safe, sober space to support lasting recovery. We know when they come to their appointments for recovery, we may only see them for an hour or so for their therapy appointment. They need another space to be, a place to live their lives, to have fulfilling, enriching experiences, to maintain and sustain their wellness and recovery. Our vision is community rooted, inclusive, and recovery centered. We want all to feel welcomed there. Our objectives are to establish a drop-in center for individuals in recovery to access resources, support, and fellowship. We offer sober meeting spaces for 12-step programs such as AA or NA, and alternatives like Smart Recovery, Recovery Dharma, and personal development workshops. We would provide rental space for community-driven events such as wellness classes, social gatherings, sober celebrations. Provide a safe, healthy, and supportive social environment, even if it's something just as simple as putting together a puzzle or doing a word search with some other people in the community who are safe and sober. And we want to build a sustainable business model with diverse revenue streams, which would include fundraising, donations, income from rental spaces, and income generated from billable services. Our target population for the community center would be people in all recovery stages, everywhere from somebody who's considering, do I have a substance use problem? All the way to, I know that I do and I need help, and I'm putting in active work to maintain that. Individuals with co-occurring substance use and mental health disorders, friends, families, and allies, professionals in the health and human services field. This is difficult work, and they need a safe, sober space to be supported as well. And community groups that need a safe and sober meeting space. For example, I think about the M Society or Hilltop Counseling. They were displaced for a period of time due to the fire downtown. They didn't have a safe and sober, welcome environment for their participants in their program. They had to make do, and change where they would meet every week. If we had the Recovery Together Community Center, they would certainly be welcome in that space. Community need. Lenawee County certainly does need this Recovery Together Community Center. And we think of them in different categories. First is medical and safety. The high local alcohol use rates, overdose experiences, overdose deaths, and ER visits. We contacted ProMedica Hospital here, and we learned that in 2024, on average, 31 people per month were seen in their emergency department, specifically related to alcohol or substance use. The person a day, every day, coming in there for a specific alcohol or substance-related need. Recreation. Imagine with me, you want to go someplace for fun. Maybe MJR, love them. But they have a new bar in there. That's hard for me. Let's go bowling. I can't. There are signs everywhere for alcohol use. I hear the glasses clinking behind me. I smell it. That's hard. Our beloved Croswell. I love going to shows there. And it's hard because the person sitting next to me may have alcohol in their glass. We need a safe, sober recreation space where people can learn to have fun and fulfilled lives that doesn't include alcohol. And then I just think about the mass exposure. Driving down Main Street, how many cannabis-related, kratom-related, alcohol-related businesses are there? Walking downtown, while there is that large blue line that allows people to be walking around with their alcohol, that makes everything downtown harder for me. Even if I just want to go to a comic book store, people are able to have alcohol out and about. It increases my exposure. I would love to have a safe space to go and have fun and feel supported. Our planned activities for the community center include peer support groups, digital literacy and employment workshops, monthly sober events, computer lab access, daily structured and unstructured recreation time, therapeutic groups on various topics. As mentioned before, various recovery meetings. In this community, we do not have a lot of alternatives to AA and NA. While they are wonderful programs, they don't work for everybody. So having space for something like Recovery Dharma or Celebrate Recovery or Smart Recovery, those would be available here. And cross-promotional events. I mentioned the comic book store. Wouldn't it be fun to have a trivia night with the comic book shop? and the community center, or a local dance studio who comes in and does like stretching classes or introductory yoga. Coffee shop. We all love our caffeine and our coffee and donuts. So those are just a few planned activities, and those activities are important. We already submitted our proposals to you, so I'd encourage you to flip through to page 6 and see all those benefits of pro-social activities. So to highlight a few, reduced isolation. When we are alone, we don't make the best decisions. So being social with other people who are recovery-minded will help sustain that recovery effort. Peer supports, people who have been there. Reduced relapse risk, alternate activities. When you take away a coping method of maybe using alcohol or other drugs, the stress is still there and they don't have anything to deal with that. So giving them alternatives, stress management, and community involvement. There are a lot of people in the community, and you guys are examples of that. People who want to be there and want to help. So I'm willing to bet there's a dance studio owner or a coffee shop owner who's like, yes, let me help. I will donate coffee. I will certainly perform a stretching class for your participants. Just to name a few of those planned activities and all the benefits that it could have. We are requesting a budget of $300,000. This would include staffing, a center director, peer recovery coaches, administrative support, and therapists. A facility, we're asking for an initial down payment and renovations if needed for a facility. We're not asking for it to be bought outright. We're just asking for an initial cash infusion to help us get started. Supplies for groups, workshops, and outreach. Technology, we want to have access to computers, internet connection, and some administrative costs. Accounting, scheduling, and we want to make sure that we're in compliance in managing monies appropriately, so that would require some administrative costs. And sustainability, which may be the most important slide of them all. We want our community center to be sustainable for the long haul, not just for a year, not just for 2 years. And we propose to do that by having that diversified revenue stream to ensure that ongoing sustainability. We would participate in fundraising efforts, recruiting volunteers from the recovery community, requesting donations such as markers, back to school supplies, puzzles, games, insurance payments from billable services, rental revenue from sober events. I mentioned that recreation activity. Maybe somebody wants to have a birthday party, but they can't have it at ZZ's. Maybe they would want to have it at this community center. Community recovery meetings in office spaces not used by MVA, and diversified education workshops such as parenting classes, our driver's intervention program, which is geared for first-time driving offenders or possibly repeat offenders, depending on their need. A distracted driving program. Remember that you get charged for using your cell phone? We could have a class on that. Gambling intervention, smoking cessation, just to name a few. Our expected project timeline would include Q1 planning, team building, and our early fundraising efforts to maintain that sustainability. As we mentioned, we don't want to wait until a year and then start fundraising. We would want to start planning our yearly fundraising events now, Q1. Securing a site in Q2, begin any renovations that might need to happen, and develop our programs. Q3, we would have more marketing and staff training with a soft launch, including people that we already interact with. And in Q4, having a grand opening with full operational launch community-wide. Years 2 and 3 certainly would be focused on those sustainability efforts, efficiency evaluations, and outcome measures. And as we are known to do, exploring are there expansion efforts that need to happen. Like I mentioned, the distracted driver. We don't have a lot of people getting those charges yet, that would require intervention class, but I foresee it happening by year 3. Thus far, we've already received quite a bit of support for this community center, including Dr. Julie Yarrow, the president of ProMedica Charles and Virginia Hickman Hospital, Jennifer Mitchell, the executive director of Michigan Certification Board of Addiction Professionals, or MCBAP, Ashley Palmer, the executive director of Encore Dance Studio, located right in downtown Adrian, across from the Croswell, Therese Langen, a partner in the community. She is the director and lead clinician of Parkside Family Counseling, and Jennifer Ermiger, director of counselor education of Siena Heights University. We have partnered with her many times and hosted a lot of her interns, so she's familiar with us. In conclusion, the evidence overwhelmingly supports the need for recovery community centers and pro-social activities, which offer substantial benefits, not just to individuals in recovery, but also to the broader community. These centers reduce public health and criminal justice costs, promote social cohesion, increase civic engagement, and improve public safety. By providing a supportive, safe, and community-centered environment, the Recovery Together Community Center will enhance the well-being of many individuals and the overall vitality of the community. And now I give space for any questions.
Good timing there, you say 5 minutes early, so. Questions from the commission, from the members? Mrs. Helmani.
Hello. I did, going through the RFP, some of the questions that came up, I saw some words that mentioned billable services. So I was interested to know, what are the costs to the individual? What has cost to it and what is free for the clients?
Great question.
Mhm.
So we mentioned like community center and membership and stuff. We wouldn't charge a membership fee or anything like that. There aren't co-pays. We would bill insurance like a Medicaid, or if they had private insurance for something that's billable. For example, like a therapy session that might occur because somebody came in crisis and needed some support, or case management services.
Okay, so the overall program would be free to the clients?
Yes.
Besides probably those instances?
Yeah.
Okay. Thank you.
Yes.
Commissioner Collins.
I have a few, excuse me, and I'll go through quickly if I can, but I would have, you have 4 applications in today, and I'll ask this for all 4. Have you approached anybody else for funding for these programs?
For these, all 4 of these?
4.
No, we have not. However, we have some leads on ideas. For example, we are minority-owned business. We are a female-owned business. So there are some funding opportunities because of that. If the site were located on Main Street, there's opportunities for developing Main Street grants.
So you said if it were located on Main, so you don't have a specific location in mind.
We have one in mind, but we have not purchased anything.
I looked through the budget, and one thing that kind of struck me, facility costs for rent, mortgage, utilities, maintenance, insurance, and you mentioned any rehab that might need to be done.
Mhm.
You're gonna do this with $45,000? I don't see how that can be done.
That's our initial down payment.
I guess my point is you're not asking for enough.
I know. I feel like we're pretty conservative in our request as well. However, we want to make it very well known. We're not looking for somebody to buy everything and continue to funnel money into this.
So understand me, 45 is your down payment. How are you gonna insure and maintain and heat it and so forth? With what funds?
With our existing budget that we have,
You have
our existing operating budget.
money for this program?
No, for our current program that we have running. So to be transparent, we currently rent where we provide outpatient services. So we could relocate and pay rent or mortgage to this new building instead of this one. So it could be
You
shipped.
plan on taking this program uh, coexisted with the program you currently have, same building?
Correct. Yeah, that way we could have in one portion of the building, the community center, and in a separate area, have our outpatient services. So if somebody came to the community center and needed outpatient services, we could offer it there, or we could refer to a community provider, depending on their choice, of course.
Do you have a specific marketing and finance plan in place to
We do.
help your folks? And will this be limited to Lenawee County or is it open to anybody?
I think it could be open to anybody. Certainly our target audience to start, the population would be Lenawee County. But I think if we develop the type of program that we're planning on, I think people would come from out of town to what we have.
Even out of Lenawee,
Pardon?
even out of Lenawee.
Yeah,
Okay, thank you.
yeah.
Sheriff Rivera.
Is this program like the one in Hillsdale, or you envision it being like the one in Hillsdale?
The program we have in Hillsdale County is a residential program where people go and live there and receive 40 hours of services. So this would be very different from that.
Other questions? Mrs. Pamani.
One more. In your proposal, I saw mentioned, and this is just out of curiosity, special services for women. And I was just wondering if you could expand on that slightly?
Yeah, absolutely.
Would that-
So, the state has put out a mandate to have specialized services for women and children. The name's a little bit of a misnomer because some men do qualify. Also now, in light of, preferred pronouns and gender identities, non-binary persons do qualify, but we are the only women's specialty service provider in the county. So we would continue to offer those services. And those things include like specialized assessments and screenings, additional supports such as transportation, childcare, basic needs. And we also absorb some of their children as kind of like a ancillary client. So while we may not provide direct services to their children, we screen them all for pediatric needs and give referrals for appropriate providers.
Thank you.
Mrs. Zix.
Hi. So let's go back to if the community center was in one building with counseling. How and what measures are going to be taken to ensure confidentiality on the counseling side as opposed to the community center side, which is generally open to public, right?
Yes, great question. So if we're able to obtain the building that we're looking at, it is divided by a long hallway that could easily have a door installed with some security measures where you couldn't cross back and forth unless you were a designated staff. It also has separate entrances, so if we chose not to have that and just build a wall, that's also an option. If we do not acquire the building that we're looking at, then obviously we'd have to come up with other planning, but that's definitely important to us. We also wouldn't want, like people having access, for example, if the counseling portion were closed and the community center part was still open, we wouldn't want somebody to be able to have access. We would want to maintain confidentiality.
Sheriff Rivera.
One last question. If you don't get the funding from this, do you plan on moving forward and with your plans to get that building and do the same thing?
Yes, we do. This certainly would help us a whole lot. It would be a necessary cash infusion. But whether we're supported or not, we do have this vision. We think it's very important and we're willing to make adjustments of how we need to make it happen. It just might not happen as fast or not be as large and robust without the support. So we do hope that you support the community center.
Commissioner Collins.
You plan on hiring additional staff, I assume, not staffing us with current personnel in your operation?
I think our existing staff would be a great addition, but we certainly would need a few more people, you know, like a program director specifically. additional peer recovery coaches to be present during community center hours.
What kind of hours do you intend to operate?
We were envisioning something like 8 AM to 8 PM or maybe 12 PM to 8 PM, something like that. I think it would depend on staffing.
Also have weekends available.
Yes.
Saturday for different workshop programming, different, one rent in the community, having, maybe Friday evenings and then Saturdays, for the need.
Yeah, thank you for that. I was just speaking of like the open walk-in hours.
I have another question. With the peer support team and it being a center, is that the availability that the peer supports will be able to pick up a person and take them to the community center to try to navigate, to try to possibly find residential treatment or placement?
We actually have another proposal for recovery coaches and we have a proposal for transportation, but it's all coming together, right? Seeing this bigger vision of going towards people, helping them, meet them where they're at, maybe bringing them to a safe space to have the conversation.
So to get myopic with this proposal, the peer supports are engaged in the community center only?
No, they would be in the community center and operating as they do now.
Okay.
They can go to people's homes.
All right,
Yeah,
thank you.
Well, thank you very much for your time.
thank you. I appreciate it.
We'll now hear from our next request for proposal, peer supports from McCullough, Vargas and Associates.
Right, thank you. Yeah, so piggybacking on what Melissa was talking about there, all of our proposals are kind of part of the same vision, and, it's interesting that Bridging the Gap is the name of this committee. Bridging the Gap is something that's been inherent in MVA's, or McCullough Vargas and Associates philosophy since its beginning. The company was started by my father, Roy Vargas, and his partner, Gary McCullough, and it was done because they saw a need in the community way back in the late 80s, early 90s for quality substance use disorder treatment that really wasn't as readily available as it could be. They were both running programs at the time in Monroe and Toledo and decided to start MVA and provide services here part-time. They found success in that. They found the need was, they were meeting needs. And eventually they decided to quit their other jobs and dedicate themselves full-time to what they were doing here in Lenawee County. And we as an agency, since its inception have had this as a kind of mindset. How do we bridge the gap? How do we fill needs that are not being met in the community? When there was a need for targeted intervention for drinking and driving offenders that wasn't being done, we started the Driver's Intervention Program. That's a program that's still running today. When the court system needed high quality, secure drug testing, we did the research, we invested in equipment and training, and we created our own laboratory to help meet the needs of the county courts. As Melissa said, in the mid-2000s, we attempted to start a residential program here in Lenawee County. We bought the Eagles building on Winter Street, and for a variety of different reasons, we're not able to move forward with the vision we had of creating a residential program in that building. I was actually kind of glad to see it demolished recently, as it was a kind of a reminder of something that didn't quite work out. But that's when we pivoted and decided to partner with Hope House out in Hillsdale County, which had traditionally been a sober living environment for men since the 70s, since 1974, as old as I am. And so then we eventually turned that into a men's residential program and then added a women's residential program as well. And we have visions of and goals of still creating a residential program here in Lenawee County, as well as transitional housing. It's not part of our proposals, but I am just putting it out there as that is part of our overall strategic development and expansion that Melissa mentioned earlier. We like to be a full continuum of care provider for our community. That goes from residential treatment, all the way through intensive outpatient, outpatient, transitional housing, whatever the needs are. And so, so it was interesting when we first heard about this, you know, it was like, hey, this makes a lot of sense for us to get involved in something like this. That's what we do. It's what we specialize in. And this mindset of bridging the gap, you know, and eliminating barriers, bringing people together in the community is something that we really hold dear as a value as a company. You know, and peer recovery coaching, you know, this is another effort of bridging that gap. You know, peer recovery coaching has been growing and growing over the last 20 years, I would say, getting away from just this traditional treatment model of, you know, you go to a place, you go there for an hour or maybe for a group and you get done and you hope for the best. Well, you know, with people with lived experience that people can relate to, it's a very powerful force when it comes to enacting change in somebody, particularly somebody with a substance use disorder. It's amazing when, I don't know if amazing is the right word, but it's interesting, at least. When people first meet me, when I first introduce myself, you know, they see me in my button-up shirt, my slacks and my dress shoes and everything, and they have a certain perception of me. But when I tell them that I'm a person in long-term recovery, you know, and I've been where they've been, that I've been arrested before, that I've been on probation, that I've absconded probation, that I've been fired from places, that I've been broken up with, you know, have all these issues that go along, unfortunately, with substance use disorder treatment, it really helps them to see and relate to me in a different way that maybe they wouldn't have been able to otherwise. And that's really one of the strengths, the huge strengths of peer recovery coaches, is that relatability and this different connection that they can develop with the people that need substance use disorder treatment. And so we already have peer recovery coaches. There are peer recovery coaches operating in many agencies throughout this county. Thankfully, it's a very needed service. And what we're trying to do with this proposal is help us to expand those services, as it says here. You know, and the goal is to reach those people that are not being seen, and to, you know, make those connections and meeting people where they're at. You know, this could be, you know, out in the country somewhere in rural Lenawee County. It could be in the Lenawee County Jail. We've done work in the jail for years and years. I've run treatment groups in the jail. We haven't done that so much after COVID. A lot of things changed. And we took a little bit of step back from that, but that's something that we are interested in reconnecting with and providing that outreach and that intervention, you know, for people that are incarcerated. Hospital settings. As Melissa mentioned, we've recently started a partnership with ProMedica Hospital to provide peer recovery coaching services in the hospital. We're still trying to work out the details of what that's going to mean. Is it going to be strictly an on-call, or are we going to have somebody stationed there, you know, throughout the evening or different times? But that's a partnership that we're very excited about. It's something ProMedica has wanted to do for a long time, and for a variety of different reasons, it hasn't materialized until now. Not just homeless shelters where, you know, the Share the Warmth shelter is doing such a great job helping with people that are unhoused in our community. Certainly we'd like to partner with them to provide some services, but also going to meet people that haven't gotten that far as some type of intervention or help, meeting them where they're at in homeless encampments, different areas that we know that homeless congregate. You know, I mean, it's like right across the street here, if anybody knows, in Comstock Park, behind the high rise, out behind different businesses on Main Street. Those are all areas that we know people go. Island Park, those areas by Family Medical Center. So being able to go and meet people where they're at, literally sit down next to them on that bench or in that grass or wherever it is, and try to have this kind of engagement and let them know what services are available, even beyond what we're trying to do as far as SUD services, and get them connected to the community at large, because there are a lot of people in this community that want to help. And then again, as here, focus on this early intervention, outreach, and engagement. I think I just outlined, you know, how we're planning on doing that. The peer recovery or the community center is another area, you know, that would be staffed by our peers and would be another point of engagement, you know, to get them involved, not only with just us, yes, it would be very convenient. We're on site, but again, everybody has a choice in who they choose as a provider. So we can easily link them up with other agencies or other help that they need in the community as well. So I think I talked about a few of these things on the next slide. Why peer recovery coaches? Again, that lived experience is such a connection. And I tell my clients too, and our clients, I should say, that, you don't have to be in recovery to treat somebody with a substance use disorder. I tell them, I use the analogy, doctors don't have to have cancer in order to treat cancer, or diabetes in order to treat diabetes. So there's plenty of practitioners that are not in recovery that are very effective and very helpful. And in the mind of the client, in the mind of the person looking at services, any little bit of connection or that extra connection can really make a difference. So some of the things we're trying to do, reduce those hospitalizations. Yes, we're going to help as people, are at that point of contact at the hospital. Maybe we help them from being readmitted within the same month or within the same week, or even the next day sometimes, given the circumstance. Trying to help reduce that legal recidivism. Obviously the sheriff and Mr. Collins can speak to this almost continual flow of seeing the same people over and over again for a lot of these same issues, not just possession or distribution, but drinking and driving, domestic violence charges that are perpetrated under influence of alcohol, assaults, things like that. So trying to reduce that legal recidivism, keep people out of jail, keep people out of the criminal justice system as well. It is cost effective, therapy is expensive. Even Medicaid funded therapy is expensive, and it's expensive to provide. Peer recovery coaching is not free, but it is a cost effective measure and way to kind of enhance not only outreach and engage people, but enhance their existing services they're seeing, in addition to their individual counseling or their group therapy or whatever they're engaged in. And then the last one here is critically important, I think. And that's why I want to, again, applaud everybody for being willing to sit in on this committee and help make these decisions to combat this stigma that we still have, as a society about substance use disorder and the way it's viewed, not as a medical disorder, not as a mental health disorder, but as a moral failing. And yes, there are a lot of moral lines that get crossed and broken as a result of people's substance use disorders, but we also have to understand that when people are committing these acts and doing these things, they're not in their right mind, and that's what we're trying to do, is help people get healthier, think healthier, behave healthier. Okay, so next slide here. So what are we trying to do? Hire and train. This says 1 full-time and 3 part-time PRCs. Now this is one of our, this is our goal as of now, and this I think is sort of a fluid goal that, we're looking to expand. The more the merrier, but we also have to be realistic about what we can do. And as Melissa said, we are doing these programs, but we're asking for some help to try to enhance these programs, to try to expand these programs. MVA has been a small, independent, family-owned business since its inception. And we try to do what we can with what we have, and I think we do a pretty good job. And sometimes we need a little help, and we need partnerships in the community, in the region, and with the state. And so that's what we're asking here is some help getting the funding to get as many people as we need to meet the needs of the community. We talked about this increased mobile PRC services, and that's going to be another part of our next presentation when it comes to transportation. But we want to have more people in the community center, in our offices, at the hospital, just wherever it's needed. Lenawee County is a big county, but it's very rural. It's very, very, spread out. And so being able to be mobile and go and meet people where they're at. Yes, we have telehealth services. We utilize telehealth services. And sometimes in order to get somebody to participate in that, We need to be able to meet them where they're at and get them engaged. And so that's what we're going to be trying to do, is to get more mobile with our services. And again, this integration into the current treatment structure that we already have. I put in there the hospital workflow. We're still trying to work out, what that's going to look like. As far as engagement goes, it's going to be an on-call basis, or if somebody's going to be stationed at the hospital, they have said that they will allow space for us there too. It's just going to be a matter of figuring out what's going to work best for everybody involved. And then again, like I said, continuing to build that referral network in the county. We're not the only one providing services. We're not the only way to help people, and we want to be able to connect people to services in whatever capacity they need. Okay. Target population is going to be adults. That's who we work with. That's who these services are designed for. We do some work with adolescents and children, but that's a separate part of our business currently. All these different areas: homelessness, incarceration, DV, survivors, Catherine Cobb partnering with all these different community areas that could benefit from increased peer support. All those are high need, underserved areas that we see. I'm thinking about other communities in our county. Is there any services at all in Morenci, in Hudson, Litchfield, or the other even smaller townships that still have residents and still have needs? And so you see these key locations that are going to be targeted. I think I've talked about those already. So moving on, some of this data, where we always want to be evidence-based and have that as a basis for what we do. The research is there. And so what we found in Lenawee County, 449 treatment admissions in 2024, that's just treatment admissions. These are people that have successfully navigated and gotten linked up with a treatment provider and entered into services. This is not including the people that called or tried to call and for whatever reason did not connect or it didn't work out. And it's definitely not including all the people that are in need of services in Lenawee County. Unfortunately, in 2022, we had 28 drug-related deaths from overdose. And those are acute mortalities. We also know that substance use disorder contributes to a wide range of negative health outcomes. And as you see here too, speaking of negative health outcomes, 368 hospital patients with SUD seen in 2024. That's a little bit less than 2023, but it's still over one a day, right? Over 30 a month, people that are seeing just for SUD specific services. So the needs are definitely there. Okay, awesome. Thank you for that. So kind of moving forward into the timeline and phases now, this is obviously the timeline starting here is in fiscal year 2026, October, before any of these awards are going to be in place. But Melissa had touched on it, and we've touched on it. These are programs that we, have goals of implementing. And that's why, we're starting the process now of getting this started, because things take time. This process takes time. Getting the disbursement of funding takes time. And so we want to do as much as we can to be prepared to be able to move, when and if this funding is provided. So you see this pretty quick timeline here, of October to December, this hiring and recruitment. We've already started some of these memorandums of understanding with different partners. We'll continue to do that, moving forward, getting all this training done. We would like to hire people that have already been CCAR trained. That's the standard for peer recovery coach training in the country. There's a couple different ones, but CCAR is one of those kind of gold standard ones. So that takes generally at least a few weeks to get people trained. That's just the specific training itself. That's not also the onboarding and the training with our staff as well. And then launching these services, hopefully April 2026, and then continuing this ongoing evaluation and improvement. Quality improvement is one of those things that we are constantly doing as an agency. So we're going to be looking at the number of people that we engage monthly as some of our measures of success. How many referrals that we're helping them to to enact, and then, how, following up and seeing how many people are actually following through with those referrals. We're trying to reduce hospital and justice system involvement, and that's going to involve some partnerships and some data. We already have that with the hospital. We've been involved in partnering with Lenawee County courts and for decades. And so we have a good partnership with them that we feel confident that they will help us with some of this data as needed. And then looking at stakeholder satisfaction, how are people perceiving the services that they're receiving? That's always important for us. That's great feedback to know what we're doing right, what we could improve on, what we could do more or less of. And then the budget overview is next, just real quick. These personnel costs, that is really the main cost for a lot of what we do is in personnel costs. So this would be hiring these multiple people full-time, some part-time, all the supervision and administrative support that goes along with that. The training that we talked about, or that I talked about earlier, these outreach efforts, this would be, some different materials that we might use to engage with people. And then this technology and data management, these different ways that go along behind the scenes of making programs like this work. There always has to be this extra backbone. And so we see a total of $165,000 in this. Real quick, this Medicaid, how are we going to sustain this? Well, Medicaid billing, peer recovery coaching is a Medicaid billed service that we can provide. We're also looking for other support in the community of in-kind and other grants that we could become eligible for and that we'll pursue, different foundations that are looking to give back to the community, and then doing this ongoing training evaluation that is just inherent in what we do as far as quality improvement. Okay, so in conclusion, I don't know if I have enough time, but I think I talked about all these things at the beginning, so I'll just leave it at that, and then I'll open it up to questions from anybody that has any questions.
Very good, right on time.
All right, there's the alarm. You did it.
Questions? I'm gonna shut off here. Come on. Questions? Commissioner Collins, sorry.
Again, I have a few.
Sure.
I did, by the way, know Roy and Gary very well. Good people, both of them.
Thank you for
I
saying that.
think did some wonderful things. I'm seeing kind of a large program you people are undertaking with various, these four, your existing programs.
right.
Other things. Is it not going to be an overwhelming activity with all of these involved to administrate with the two of you?
Well, the quick answer is no. And that is because we operate on a team dynamic at MVA Behavioral Health. Melissa and I are kind of at the forefront of leading as far as administrating, but like as far as this goes, we have a lead peer recovery coach that has, a lot of years of experience that would be helping us, spearhead this project. What's that?
To administrate that.
Yeah, to administrate. She would be in charge of supervising the other peers and things like that. And so we look at everything we do as a team effort. And also we look at things realistically, and taking things one step at a time, and that's kind of what we're doing. With this is not a brand new program for us. We've been doing peer recovery coaching for many years now. And we have currently between our Hillsdale and Adrian office, we have about, I think 7 peer recovery coaches in total. That's between the 2 counties. So we already have the experience, as far as this goes, to, again, not create a new program, but to expand what we're currently doing. So I do take what you're saying, to heart, because we do have a lot of goals. We do have a lot of ambition. And
Of ambition.
yeah, and what we're doing, is generally what we're doing is building on what we're already doing. The community center is a new endeavor, so that would be taking a lot of our time, right, to make sure that that's going to be the best thing it can be. And we're experts in the field. We don't know everything, and so we would be reaching out to people that do have experience in this area, to give advice. Luckily, Melissa and I have met many people along the way throughout our journey, in this field and feel confident that we have support and resources available, to help us make these programs a reality.
One final question, and
Sure.
this comes from experience on my part.
Okay.
Any of these programs currently, or any of these programs you're talking about, approach or deal with families of those with abuse problems?
Most definitely, substance use disorder is not just an acute thing, right?
Well,
It definitely helps, it definitely affects the individual, but no individual is an island unto themselves, right? We all have families, we all have friends, we all have communities that we're a part of. And so, yeah, we definitely help to treat families. We can get people in for family sessions, as needed. We could treat just the family member as needed. This is one of our goals as far as some new things that we're not asking for funding, but Melissa touched on it, is these parenting classes. We're looking to launch a parenting program in the county to help strengthen families, to help, people understand what are healthy ways to parent their children. And because we know that addiction and many other disorders are cyclical, they're chronic, right? And so we see these patterns repeated over and over again. And so what we're trying to do is to arrest some of those unhealthy patterns and to get people on a path of health and wellness in the other direction. So yeah, we definitely planning on treating and do treat families currently.
Ms. Zick.
Hi, you put in the PowerPoint about to combat stigma. Can
Mhm.
you address how will you combat stigma with this program?
Well, I think there's many ways we can do that. Being out in the community is one of them. We regularly participate in community events, Day of Hope, Pride, Erase Stigma. We have a team every year. We sponsor that event every year as well. And so that's the big thing is, to me, it's normalizing this as something that, as a health disorder that affects a lot of different people. And that there are a lot of people that are very healthy and happy and doing well once they've gotten into a long-term recovery program. And myself, Melissa, many of our other employees and many other people in the community are shining examples of that. And so peers are kind of on that front line of leading the way and showing that, hey, yes, whatever has happened in the past has happened, but now after these changes and finding, this recovery, and look at what I'm doing now. I think of one of our newest peer recovery coaches, LC. He had decades of criminal behavior, unhealthy behavior, and going through not only treatment, but recovery, the adult recovery treatment court here in Lenawee County. He's been sober for years now, and he just came on board with us as a peer recovery coach a couple months ago, and he's doing great. And so showing that lived experience, having that outreach, showing that there is a different way, and that substance use disorder doesn't just have to end in jails, institutions, and death, as we say in the program, that there's a lot of other things that can happen once people find, achieve, and maintain recovery. So, yeah.
Ms. Palmani.
Hi, I was just curious, the cost to the client it's all billable to Medicaid or whatever insurance they might have?
Yeah,
Or is there
Medicaid.
Additional
Oh, I'm sorry.
cost? I'm sorry, just is there additional?
Yeah, I mean, there's not going to be any cost to the client for this.
Okay,
Our goal is, like we talked about, is outreach, is meeting people where they're at, is engaging them in services, engaging them in recovery, exposing them to recovery. And yes, it's nice when some costs can be recouped through billable services.
Mhm.
And we do everything we can in order to do that, because without that, it's hard to operate, right?
right,
And so we're going to find ways that, that we can bill through Medicaid and other means, but we're also prepared to do some pro bono work as well. Because right now, like, just to be transparent, for having peer recovery coaches in the hospital, We've been told those type of services, outpatient services, will not be authorized in the moment. Like if somebody goes to the hospital and they need, say, acute care, like withdrawal management or residential programming, they can call the after hours, access line and get connected. That's not the case for somebody that wants to engage in peer recovery services or not at the outpatient level. They would have to wait till the next day. Sometimes waiting till the next day is too long. The best time the best time to give services to somebody that wants them is when they ask for them. And so if we don't get paid for having our person go and engage at the hospital, it's worth it to us for them to be able to engage in recovery and meet somebody and get that kind of support. And then we'll see later on if we can, do some other things that would help recoup the cost as far as the
Okay.
billing goes. Yeah.
Okay, and also I have had some interaction with some peer coaches
Mhm.
when I was trying to help a young friend.
Okay.
And they were very cool.
Yeah.
How available are the coaches to the person with the substance use disorder?
Well, that is a goal of ours. It wasn't really explicitly stated in that, but with being at the hospital, there would be some type of on-call rotation that would happen. And so we're looking at that, how can we implement that as on-call right now? Our peers, we kind of leave that to their discretion, especially our lead peer coach has been doing it for a long time. So, she'll answer calls in the evening, within reason. She also has a bedtime. She also has a life and family. So, she knows when to set boundaries as well. So the more peers that we can have available, the more opportunity there is to meet people where they're at whenever they need it. You're welcome.
Thank you. So the next presentation will be Transportation Access Expansion Proposal by McCullough Vargas and Associates.
Okay, so that is also the one that I'm going to be presenting. Let me see here. Okay, so again, I think the question was asked, or it came up earlier about how are we going to get people to this center? Are there going to be peers that can go and pick people up and get them connected to this center or anything else? Well, hopefully the answer is yes. Right now, yes, our peers do transport clients as needed. But what we're asking for is something that's more dedicated, right? Something that's more specific. I think we're switching over to the next presentation still, which is fine. So what we're trying to do is to purchase a specific vehicle for recovery services. So it's been code name is Recovery Ride right now. I don't know if that's what's going to continue to be the name moving forward, but having a dedicated vehicle that can help people get to treatment, get to recovery groups, maybe get to other appointments that they need based on their case management needs as well. We've talked about, we can go to the next slide, please. We've talked about the rural nature and the far-flung nature of the communities outside of the county seat here in Adrian. And so what we're hoping is to help people that are living in some of those more outlying communities, help them get connected and meet their appointments and get safely back and forth to treatment. We've had this idea in mind for a little while now, but it's really come to the forefront just in the last couple of weeks for me, where we've had multiple times when we've had clients sitting in our waiting room for hours waiting for Medicaid transport to come pick them up, or some other ride that fell through. Unfortunately, as I was coming back to the office, I saw one of our clients pushing her tandem stroller with both her young kids down the street because her ride fell through and there wasn't any other available transportation in the moment, and she felt the need to walk instead. And so those are some of the things that we're trying to eliminate, these barriers to treatment. And transportation is unfortunately a large barrier. And so what this is trying to do is to have this person-centered care, meet them wherever they're at, have this engagement through mobile outreach, and also getting them connected to the services that they need. And they might not always be our specific services. It might be some other things in the community if we're working with them and some other case management needs. So these are the things that we're trying to do here with this transportation project. So the objectives here, purchase this vehicle and outfit it. We're looking for a 12-person capacity vehicle, which is kind of a specialty vehicle. I think Mr. Cliff probably knows a little bit more about that, but you don't find 12 passenger, vans like that that are outfitted the way we need it, just on every lot you look at. So, we've already been doing some research into this. That's why, some of the numbers are what they are, in our budget. But looking at some of the best deals there and something that's going to be affordable, that's going to be safe, it's going to be reliable for our clients. And again, we're talking about eliminating that transportation barrier. The best time to engage people is when they say they want treatment. And when there's a delay in treatment and there's a barrier to treatment, it might be a while till you see that person again ready to access treatment. And so we want to make sure that that's not an issue for the clients that we serve. We've talked about, and again, goes hand in hand with our peer services and these outreach efforts that we're trying to do in the communities at large in Lenawee County. And again, this no-show rate and service engagement are what we're trying to prevent, because it's been proven through research over and over again that the more often and the longer that people engage in substance use disorder treatment, the greater the likelihood it is that they're going to have long-term success in recovery. And so this is another area or another way that we can help people engage on a regular basis, long-term, to have the greatest level of success moving forward. So our target population is the same one that we've been talking about, adults with SUD or co-occurring mental health disorders. We're still kind of in the planning stages of this and still, looking at working out all the kinks. Are we going to have, if clients have children also that they need to bring with them to treatment, are we going to transport children as well? And so looking at, what the ramifications are of that. But in my mind, the answer is yes. Because again, that's another barrier to treatment is childcare. And so that's why we have in our offices, we have a little playroom, a little play nook for kids with toys. And if our clients have to bring their children to treatment, they can still be there. So there's plenty of people that don't have reliable transportation, unfortunately, in Lenawee County. And because of the rural nature of it, it's 20 miles sometimes to some of these outlying communities. That's a long way to go if you're going to try to ride a bike or walk. That's going to take you maybe a couple of days. And so we're trying to help people that don't have that transportation. And I talked about some of the outlying areas outside of the county seat here. And so again, more supporting data. Why do we need more engagement? Unfortunately, overdose deaths in the county have quadrupled in the last 10 years. And that's for a lot of different reasons, different substances and things like that, but it's an undeniable truth that is happening. I was shocked by this. Only 0.3% of residents use public transportation in Lenawee County. That's hardly any at all. Okay, and we do have some transportation, right? Lenawee Public Transportation Authority, they do a great job. They do what they can, and they have limitations, right? They have limitations. They can only do so much. They have certain hours of operation, right? And they might not always align with, the needs of our clients. Say they need appointments in the evening, they need connections to different recovery community, different peer-led recovery meetings, which often happen in the evenings too. And so this is where we see, being able to fill that gap that is not there. I don't know, is there a taxi service in Adrian anymore? I don't think so. There used to be. There's Jeff's Rides too, right? Which is kind of picking up the slack. There's, I think, maybe some Uber drivers or Lyft drivers, but again, there's a cost to all those things too. And so, looking at this number, 85% of those needing treatment do not receive it. That's a staggering number. And that's something that we're working to bring down. It's never going to be zero, I doubt, but we can definitely do better than 15%, I think, getting services. So this project timeline, looking at the first of the year to start planning and vehicle research. Now, to be honest, like I already said, we have been doing some preliminary planning on it. But until we know how much funding we receive, if we receive it, hopefully, we won't know specifically what we'll be able to purchase. So we're looking at, those first couple months, the first of the year, looking at it, making a final determination, around in March, getting people oriented to, the program, developing, our policies and procedures, making sure we have all of our insurances and everything, up to date and things like that. And then launching that service around springtime there in May. And then this ongoing evaluation as far as, what are we looking at? It's going to be scope of work here is similar to that timeline. We're going to be looking at 30 to 50 client transports per month. We've never done this before, in this kind of way. So we're not exactly sure how that's going to look. That might be a very conservative number. Hopefully it is. That means that we'll reach way more people than that. As far as getting them to and from treatment or other recovery related activities, and then doing these weekly outreach trips to homeless communities, rural towns, things like that we talked about in the peer recovery coach expansion program. And then, like everything we do, we're going to collect data on it. How many people are we seeing? How many appointments are being made and being kept? How many referrals are being, seen through as a result of this? Those are the things we'll want to take a look at. And this is very related to the next slide, which is success measurements. So again, improving that attendance and treatment retention, they go hand in hand. The more engaged you are, the more likely you're going to stay engaged, and, that's going to go hand in hand with our service delivery of what we're doing at the outpatient level. So reducing those cancellations and then looking at client and staff satisfaction and transport with the service. This is something we do with all of our services. We do customer satisfaction surveys, client satisfaction surveys to get their input into the services we're being delivered. And we also do this on a regular basis with our staff people as well. Because Melissa and I are only two people. We can't be everywhere and do everything. So we need that engagement and that open line of communication with our staff. And that's really something that we pride ourselves on and really hold dear as a company is excellent communication, not only with our clients, but within our staff. Okay, so then the budget summary here, we're requesting $100,000. The majority of that is going to go to a vehicle. We submitted a few different, quotes. Yes, quotes. Quotes from different areas that different, companies that have these type of vehicles available. And 85,000 seem to be kind of in that range. I mean, you can pay just about anything you want for a vehicle, but we want to try to be reasonable with this. And so the majority of it's going to go to that, to helping us get that going, and then paying for some of that initial insurance. The fuel is going to be a big expense. The maintenance is going to go on into a vehicle like this. And then that $5,000 for outreach equipment and outfitting. What do we need? Do we need to have things specifically on board in the vehicle? Like cameras, things like that, outreach materials, that we could help have easily available within the vehicle, if we're doing these different outreach things to give to people that we need or that we would need to give to them. And so then how are we going to sustain this? Well, use of agency operating funds. We have a general fund that we use for a variety of different purposes. One would be the maintenance and the maintaining this program. fuel costs, maintenance costs, all those kind of things. Now, you can get reimbursed for these services too. As a Medicaid transporter, you can get reimbursed from people's Medicaid plans. Different plans have different ways that they do this. Different coordinating agencies have different ways that they do this. In Region 5, where we also operate, we can get reimbursed for mileage and things like that. In this region, it's handled more through the individual plans that people have. And so there's ways to be a Medicaid transportation provider as well to help recoup the costs and keep this program sustained. And then doing fundraising in the community, getting donations if people want to donate money for gas or maintenance, or maybe some local shops would be willing to do oil changes or tire rotations or different things like that. We have visions of communicating and reaching out to different companies in the community to help offset some of that cost for a good cause, for what we're trying to do. And then finally, why transportation matters. So just kind of a recap. Improving treatment retention and reducing relapse risk. The more we're engaging, the better off we're going to be. Expanding those services out throughout the whole county, not just in Adrian or Tecumseh, which are the major cities, but thinking about Fairfield and Jasper and Clayton and all these other areas. They're just teeny little communities that still have needs. Again, trying to reduce hospital admissions, missed appointments, things like that by getting people engaged in treatment, and then supporting that equity and continuity in behavioral health care. Getting people engaged, keeping people engaged, letting people know what's available and that, hey, we're here to help. We can get you where you need to go. And that's just, something that we're always striving to do in whatever capacity, including this transportation one. So with that, I'll open it up to questions.
Questions? Mr. Cliff?
How do you staff this vehicle?
Well, the vehicle is going to be staffed by peer recovery coaches. We're looking at also volunteers, and that's how we're looking at staffing it.
Because that would probably be a pretty good chunk of
Well,
budget to
well,
try and
well, yes,
pay somebody to drive.
it is.
Big
And,
hours.
and that's what I said. The majority of our costs are in staffing, and so that's a very great point that you're making. And so the way that we're looking at this too is, again, combining the different services that we have. If we have peer recovery coaches that are manning this vehicle, right, they're going to be able to go in the community, meet, not only just take people from place to place, but have these meaningful conversations, having this engagement in there, which are billable services as well. So, and then we can have people volunteer. Obviously, that's free labor, but that's another way that we're looking to staff this.
So if somebody in Lenawee County needs transportation to their job every day,
Mhm.
is that a Lenawee County something? Does that exist?
To some degree.
Okay,
You have to make, and it shuts off at a certain time.
gotcha.
Like if you're on the night shift, there's no transportation.
I have a friend right now that I'm trying to help that's got no vehicle and needs to go, needs some kind of transportation to get to a job, has no job right now,
Mhm.
and has had addiction problems. And
Yeah. Yeah, and that's challenging. And, initially this program is designed to help get people engaged in treatment and recovery community and things like that. But like with many things, there's room for growth. There's room for different ideas. That would be maybe more of a case management type need, right? Transportation to work, how we're going to figure that out. And maybe this could be something, based on timeframes and things like that, that could be maybe a stopgap measure, in order to get somebody engaged until they can meet somebody at work. Maybe that could give them a ride, or they could make enough money in those initial, couple paychecks in order to pay somebody to take them to work,
right,
something like that. So I could envision something like that happening. It's not the initial, design, but again, that would be part of that case management need.
Other questions? Ms. Bellani?
Me again. There's no cost then to be transported, or will there be a transport?
No, there's going to be no cost to the client served. You know, sometimes their Medicaid could help pay for it. You know, we might, if they wanted to donate or something like that, you know, they could do something like that, but it's not going to be a requirement, you know, to be transported.
Ms. Zick?
So when there isn't a charge to the client, I know we said that in another presentation, there is a charge to their Medicaid if you're billing Medicaid, correct?
Right, if we were to do it
So
that,
there is a charge, but it's just via their insurance.
right, yeah, we wouldn't expect any out-of-pocket
Okay.
payment. I guess would that be a better way to say it?
Okay,
Yeah,
yeah.
yeah, and some people might not have Medicaid
Yeah,
treatment.
so you would bill Medicaid if they had it.
We
and
would-
if
we
they
would,
didn't,
yes.
there would be a zero charge.
Correct.
Okay.
Yeah.
Thank you.
Yeah, yep, and different Medicaid plans, you know, have different ways that they
Absolutely.
handle that. So yeah, so there wouldn't be any out-of-pocket expense. That's a better way to say it.
Thank you.
Commissioner Collins?
This vehicle, you're talking about new vehicle,
Yes, that would be the hope, to be a new vehicle.
handicap accessible?
We would look at that that would be our goal, yes, but that would be depending on cost and different things like that, but that would be our goal.
Gary would be the expert here, but
Yeah,
again, I think you're not asking for a vehicle that would transport that many people,
yeah,
outfitted the way you want it,
right,
handicap accessible,
right,
insurance, title, plates, transfer.
yes, yeah.
It's-
It's a lot. It's a big expense. And so, you know, our approach, we know there are many needs in this community. Okay. And we want to honor that, right? And we're asking for a lot of money through these different proposals already. And so we wanted to be conservative in our approach, you know, and because I think I think it's important for many different proposals to be funded, you know, and not just maybe one or two or five, you know, and so, and we're also, again, these are things that we're asking more for just kind of like a boost, right? An assist with, you know, we're not looking for long-term funding. We're not expecting any of the funding that we're asking for today to be the be-all end-all for us. It just doesn't make sense business-wise to do it like that. And so that's why we're being more conservative in our approach, you know, with the amounts that we're asking for.
Any final questions? Thank you. And the final proposal will be infrastructure support proposal by McCullough, Vargas and Associates.
Hello again. Okay, so as we mentioned before, MBA began in 1990. So you can imagine what the state of business was at that time, you know, paper records, maybe a singular phone, those sorts of things, you know, billing all done by hand, maybe a carbon copy, receipt book. So as we have gone along over the decades, we have tried to upgrade things, but those upgrades are costly. You know, it is very expensive. COVID really gave us a push to do some advancements with our technology, and still, admittedly, we're a little behind and we need help. And this is where maybe we won't be as humble and conservative. We're asking for a large assist in this area, a one-time cash infusion to help us bridge the gap in our own technology and infrastructure. So specifically, our infrastructure support proposal is looking to modernize MVA's technology and administrative systems, support telehealth when people cannot make it to the office for whatever reason. We can still hold an appointment with them by video and video phone call. EHR or electronic health record, secure communication, and staff productivity. We're also looking to enhance our service delivery and sustainability for core programs. So our telehealth platform that we're looking to secure needs to be HIPAA compliant, needs to be secure, needs to be encrypted, all of that, all those fancy computer words that I know a little bit about. All of that costs a lot of money, right? It's not just a regular phone call. Secure integrated electronic health record system with outcome tracking. So being able to have their chart in a safe, secure way that is long lasting. It's not going to burn in a fire like a paper chart. Papers aren't going to be misfiled or misplaced. And the outcome tracking can do things faster than what a human alone can do with trying to input data into, I don't know, some Excel spreadsheet to make make that like a chart or something. New hardware. Machines cost money, laptops, tablets, webcams, headsets to have private conversations. Centralized scheduling system with self-service for clients. So we have explored some options where clients can, in a way, access clinician schedules that show open availability, maybe similar to your doctor's appointments, where if you can go in onto their little app and say, like, request an appointment, having systems that would allow people to have more choice readily available, maybe at 2 o'clock in the morning when they're thinking, maybe I should see my therapist. Being able to put in a request for an appointment instead of having to wait during regular business hours. And having a modern VoIP phone system. That's a lot of jargon. Basically, it's voice over internet protocol system. So different from like a regular phone line, like a landline. It has some perks. It's cheaper than a traditional phone line. It offers some flexibility where I can have a phone call on my computer, for example, and then transfer it to my mobile phone if I need to locate somewhere else. It also offers advanced features like video conferencing. Unlike a regular landline phone, I could switch on a video and see somebody for a more appropriate telehealth appointment. Administrative and operations enhancements. So HR is a huge part of what we do, having to credential our staff, make sure that they maintain appropriate licenses, maintain their certifications, all of their required trainings as required by our accreditation board, our state licensing, and our regional or county oversight. So HR software for onboarding, payroll, and compliance tracking would be very helpful for us. Cloud-based document storage and collaboration tools. If myself as executive director, our finance manager, and maybe our compliance officer could all see the documents at the same time and not have it just on my computer or just their computer, this is going to enhance our productivity and make things more accurate, quite frankly. Staff training and onboarding. Just to give a little glimpse, we talked about MCBAP, or the Certification Board for Addiction Professionals. We have a lot of people in our company who have those certifications, and depending on who you are and what degree you have, their staff training requirements are between 186 and 300 hours of continuing education. That is a lot to manually track. It is hard. Having some software to give me an assist would be greatly appreciated. I also know that I would be more efficient. Us as a business would have higher retention of our staff and our clients, because we would be able to maintain their records and see their outcomes, see trends more efficiently. And we know that the data security of a system like that is greater than a paper record. Our population served is not different than what we've talked about before, serving all of Lenawee County and whoever else might happen to be a client. We've mentioned before we have our driver's intervention program, or maybe some partnerships we have with the courts. So we frequently have people from out of state that want to receive our services for like a one-time educational class or something. This would assist them bringing business to Lenawee County, even from Florida or California, Indiana. I just took a call on that one the other day. The population also includes our existing clients, children, adults, families, and those court-ordered individuals, and our co-occurring mental health substance use disorder folks. Supporting data. I mean, for good or bad, COVID really did give us a lot of research about the effectiveness of, you know, telehealth, using technology, how to bridge the gap for somebody, especially in rural towns like ours. And in 2022, it came out 91% of behavioral health organizations started using telehealth. We weren't allowed to see people in the same way. So a lot of people got on board. We did too, with $8 webcams. Did our best. We're conservative, we're humble. But maybe we need some better equipment now. Manual systems increase billing errors, and we have compliance risks. Cloud and phone system upgrades improve client satisfaction. So being able to log into your account and communicate securely with a counselor, being able to complete a screening assessment that was provided by your counselor. It's going to help them feel more engaged, more interactive, and give them a sense of agency. Like, I know how to do these things. Because when I went to apply for a job and I had to fill out a thing online, I have no clue what I'm doing, right? I don't even know how to use the internet. So helping them with a client portal, learning these different skills with a little tablet or something to interact that way. And we talked about HR, automation, reducing workload and improving retention. Wouldn't it be great if you got a little alert that's like, hey, your training's due, instead of just letting it go and then you find out later in an audit and you get in trouble? I would love that. Having some sort of automated system where I'm not manually having to, or staff is manually having to do these administrative tasks, or we can let a computer do something and assist us. Our project timeline includes first quarter of planning, procuring a vendor selection, obtaining our hardware, quarter two, system installation, and beginning setup and training with our staff. Quarter three, staff training and platform launches to the point where staff can be super users and help their clients. So not only can they be effective, but they can help clients if they need to. Of course, we still would have things like telephone, like I mentioned, the asking for an appointment. That could be an option, but also some people may not have a computer to be able to do that, so they'd still be able to call in. We'd be piloting our services, collecting our feedback, and then by quarter four, we feel like the system would be optimized. We would have our evaluation reports and final integration and refinement to any adjustments that need to be made. Our success measures include a 50% increase in telehealth sessions, having clients feel more competent and comfortable in utilizing telehealth if they need it, a 25% reduction in no-shows or like cancellations because they can't attend the appointment, 95% documentation compliance. So I mentioned like those trainings that might be overdue, or like having an alert that a consent form that's only valid for 1 year, having an alert that this is coming due, this is about to expire. We want to increase our compliance there. 99% electronic health record uptime, meaning the system is operational. It's not down because of system failure or bugs or something. It would be operating the majority of the time. 30% onboarding time reduction. Maybe you haven't started a new job recently, but think back, all the papers you have to fill out, the forms, all the things, how many signatures and how many trainings. Less than 5% support tickets. So if things are optimized and running smoothly, staff are trained correctly, we wouldn't be needing to reach out to technology support as often. And client satisfaction, user feedback tracked, having a system that can be modified and adjusted for usability. If we get feedback that maybe the language is a little bit too advanced, I'm not sure how to read it, we would want to take that into account to make the system the best that it can be. Our budget overview, we're requesting $250,000. And that would include $175,000 for telehealth, electronic health record, scheduling, hardware, cloud, and phones. 75,000 for those HR tools that we talked about, like tracking the onboarding, the software, cloud sharing, training an IT consultant to make sure that we are getting HIPAA compliant programs, that things are installed correctly. And it would include in-kind support from our agency for oversight and evaluation. We would not want to outsource that and have additional costs. Sustainability strategies, ongoing costs integrated into our annual operating budget, cost savings by automation. If I'm able to reduce the amount of time that I onboard somebody by 30 to 40%, that's going to help me a lot. That is a cost savings because my time can be converted to something else that might be income generating. Reducing IT reliance, having to go outside of the company for IT consultant on certain things is costly. Billing accuracy. We have to be accurate in our billing, and when we are not accurate because we have manually entered an incorrect code or something, we have to pay that back. And that is a cost that we could not keep having. You could be off by one number and still have to pay back. Staff trained for system support and maintenance. So we would have created super users in this, and we would want to have that knowledge passed to all staff. Any incoming staff would be competent and able to use the system. Scalability and refresh plans built into future budgets. So as we are able to have staff retention because of a smoother onboarding, as we're able to have more accurate billing and less Medicaid payback situations, we would be able to have some discretionary funds or some extra income that could be allocated to something different if we wanted to enhance the system. That's all that means. So we're not being super humble with this one. We really want some help here. Do you have questions?
Questions? Ms. Palmani?
I was just curious, I did read that, of course, you will be building, like, for sustainability purposes, future expenses with software, any of this into your budget. Would this increase the cost to your client in the future, do you think?
No, it would not. About the cost to clients, we actually, based on our nature of who we are more likely to have a write-off expense than to charge somebody. We don't turn people away because of their inability to pay. We offer sliding fee scales for things, but just because we have an enhanced software doesn't change anything for them.
Other questions? Well, Mr. Kelly?
Yeah, my question's about all four, basically.
Perfect.
Okay. There are a number of entities in this community that offer peer coaches, drop-ins, things like that. Why not look at a model that incorporates everybody? Because we have Morenci, as you mentioned, Morenci, Raisin Township, places not directly in Adrian that needs these services as well. There's people in those communities. So why not a model that looks at, that involves all those entities that do the same type of work?
I'm not sure if I understand exactly what you're saying, but one thing is, to be honest, what I'm thinking is revenue streams. So if we were partnered with somebody like Parkside Family Counseling, who is getting income from that? You know, or Lenawee Community Mental Health, like who would be getting that income? And that would definitely impact sustainability model. You know, because there's different entities, different competing agendas and ideas and values. And we also think like there is Pathways Engagement Center, but that, I don't feel like that's in competition with what we're doing. I think it's yes and. They are open 8 PM to 8 AM or some close variation of that.
Are you talking more about outreach in the outer communities? Because this is all centered in Adrian.
Yeah, well, that, and, you know, you're looking at a community center. You're looking at peer coaches, and those are the two main things. Obviously, transportation is always an issue and everybody needs that. And your infrastructure is right on. Nowadays, you need, especially in the human services world, you need a lot of infrastructure that didn't exist 5 years ago. So, but it's really the model in which you have a place for people that have issues to drop in or go and receive services and work with a peer coach to get what they need. Yeah, I'm asking for something a little bit different. I'm asking for not to be just Adrian centric. It's to recognize that each community needs these things. And maybe it is taking your van and
Correct,
going there and doing something within them. But
Yeah, the plan would be for the van to go out and then the community center to exist within. We didn't feel like we're talking about spreading thin. We didn't think that we could have a community center in each of those spaces. That would be too much. So having one community center with the ability to bring people in or just go to if they weren't ready or able to come in.
Yeah, and you know, having that central location. 'cause it
Can
would-
you stand up and use the microphone, please?
And having that central location, right, not just for the peer center, but also for our outpatient offices too. Yeah, kind of having that, you know, all-inclusive service delivery in that spot, you know, where people could not only use the Center for Recreation and Community and things like that, they could see peers there too. They could also see women's specialty services, you know, case manager. They could see therapists that specializes in SUD, mental health, trauma, you know, all those different things, kind of having all of that in one space that I don't think any other community centers currently have that service delivery here in Lenawee County. And as was pointed out, you know, we got to start somewhere, you know, and what we're trying to do is have this central location, this central hub that people can come to, but then also having, again, in partnership with these other plans, the peers, the transportation, going out to these outlying areas and maybe developing a partnership with the township or the area, and maybe they have another administrative office or something like that, that eventually they might let us use or rent out space in to provide more on-site, you know, things there. You know, we're a believer in expanding and meeting the needs of different communities. You know, we're in Lenawee County, we're in Hillsdale County, you know, and we're trying to make the best things we can in both of these counties too, you know, and then who knows, maybe expand somewhere else. But, you know, this central location and then, you know, spreading out is kind of the model that we're looking at in order to try to meet the needs of the most amount of people we can in the community, in the most, well, I shouldn't say the most amount of ways, because we don't specialize in everything, but we do a lot of things. Yeah.
Does your data tell you that, and maybe the data is not available, but does it tell you that the need is greater in Adrian than say maybe the Tecumseh area? And if it were greater in the Tecumseh area, would it be better to be centralized in the Tecumseh area?
Well, we'd have to look a little bit more specifically about that. I will say, just as a general rule, you know, Adrian is a greater population center, and the surrounding townships too, Adrian, Madison, you know, Raisin townships too kind of all part of Adrian, although
Sure.
raising, there's some bleed over. But because with the increased population, that's really where there's gonna be the increased need. But I take your point, that, we gotta go where the most need is, I think, to start. And I would say that Adrian has the most need just because of the density of population.
Other questions? Well, we want to thank you for coming today and your 4 proposals. The committee will take those under consideration. As you know, this program goes on till close to the end of the year, and then they'll be making recommendations to the Board of Commissioners for final approval.
Yes, thank you very much for your time and all you guys are doing here. It's really
Thank you.
important. Thanks.
Thank you.
Gary's still around.
What's that?
Gary's still around.
Yeah, he's around. He's retired. Yeah, he's retired now, but yeah, he's over on Madison Court over there. Yeah.
Yeah. He and I belong to a group called the Hibernians.
Oh, I'm familiar, yeah. Yeah, he's still around. He's just retired. Come on. All right, here he is.
Public comment? Any commission comments from individual participants? Mr. Cliff?
How do we allocate this money, I guess, in this particular case? And then how do we audit that that money has been used as it was suggested to be used? I don't know. I'm just trying to think this thing through.
Well, as far as how you allocate it, that will be your recommendation to the Board of Commissioners. And how the Board of Commissioners then, if they're allocating the funds, it's their responsibility to follow up on, make sure it's being used that way. But I'm sure there's going to be guidelines, needless to say. If you don't use it for what you said you were going to use it for, then, well, there may be ramifications that'll come back to your organization.
Okay, I didn't know if there was some kind of audit process or, I can see you give them a X number of dollars to go buy transportation. Either you bought the transportation or you didn't buy the transportation, but I can also see some of these other programs, how do we make a decision whether the money was well used to provide,
Yeah, I think in larger communities, if you took a community like Detroit and they're allocated significantly more money than we're allocated, it'd be very difficult to track. But I think in a community our size, if you put these programs in effect, at least the 4 that I've heard today, you've heard others more than I have. I mean, you'd pretty well know if they're not meeting their need and their goals.
well, I guess, I don't know. I mean, some of these activities, it would be hard to put a number on, perhaps. You couldn't just say, hey, we had 10 people that did whatever or whatever, it's just, how would you measure their performance would be I was just trying to think this through. So I don't want to overcomplicate.
Mrs. Zick?
So after allocations, you have to remember that monies will be rolling until 2040. So the recommendation is after the distribution of this amount of monies is probably in 3 years, depending upon minimum of 3 years of when the monies come in. In that process, sustainability in the community, if people are gonna come in and ask for money again, they're gonna have to show you data. If you're creating a new program, it's kind of hard to have data that it isn't. And there's many measures in place to ensure that accountability.
Any other comments, questions? There's no public comment? Sure. If not, a motion to adjourn.
To adjourn.
So motion by Commissioner Collins,
Clift, support?
supported by Mr. Cliff.
Oh, no, go ahead.
All those in favor signify by saying yes.
Yes.
Yes.